Thank you all for joining today for our Women's Health Month. May is Women's Health Month. If you guys weren't aware, so excited to have Dr. Pamela Miles from our OU College of Medicine, associate professor there, as well as a practicing OBGYN at OU Health here in Oklahoma City. So very excited to be able to have this, great knowledge here to talk about women's health and through the different stages of life. I joked with her the other day that I don't know if it's just because I'm over 40 and so my social media is targeting me with everything that has to do with menopause, perimenopause, and all of that sort of thing. Or if it really is just the hot topic, if you will. But I think I've heard from several others that, yes, kind of these different stages of life, learning more about women's health overall in general, and just the more and more research that tend to be seeing here, which is so happy and excited about. Really looking forward to hear what Dr. Miles has to share with us. And certainly any questions, please throw those in the chat. This is a wonderful time and opportunity to ask those questions. You can put them in the chat, and Dr. Miles is here to walk through it with us and just shed some more insight and experience and knowledge with us. So thank you, Dr. Miles.
Certainly. Well, some people ask how I even got into this part of gynecology, and I think it's because my patients I've had for years were done having kids, and now this was their next issue, and they were my people. So not a lot of it going on in the past years as far as in our education. So we are training the next docs coming out of here with a little bit more midlife women's care. We're finally trendy. Every day there's a little news story somehow relating to this, even if it's about how available your patches are or what regimens you might take or supplements. So we're in the news finally. So mostly I try to talk about being well. It is about a third of our life or more that we spend after the menopause or reproductive years. So we want to stay well so we can enjoy ourselves. Only recently I learned that most creatures on Earth can reproduce throughout their whole life. So there are some that have a post-reproductive life. So we want that to be a good part, and we're one of them. It's a time to stay well and be able to still be active. So we're going to talk about some ways to try to stay that way. We live longer than guys, but our last few years are often in poorer health. So we want to undo that little trend as well. So I did a similar length talk. I called it speed dating for perimenopause because there's a lot. I'll try and hit some of the high points, the things that I hear about on a daily basis, and things that we can and can't always fix. So we'll go through some of those, and to keep me on track, I do have a short PowerPoint just to hit the topics, and then we can free for all it with any questions after that. But I can go off track way too easy, so I'm going to use some of these to keep us going. The main things we tend to hear about are this lovely little list right here. Anytime after 40, it's, as I say, legal to be menopausal. Before that, we tend to investigate it a little differently and a little bit more to make sure it's not something otherwise that's going on to change symptoms and cycles and such. So you hear more of the people in the 40-year-old range now. It used to be kind of saved for those 50 plus who would start talking about this. And for the past 20 years or so, hormone therapy had a bad rap because of the Women's Health Initiative study that came out in 2002. Scared everybody off the hormones. It was looked at with better questions. All the information was there, and realizing that when people started their hormone therapy earlier, basically kept it going, they did well and had less risks. It didn't cause the breast cancer and things like that. So we're back on track with it being okay. Our primary care docs are getting more comfortable with it as well. So hopefully it is not going to be so hard to find a provider that's knowledgeable. So we do see most of these things on a regular basis, the different cycle changes. We have lots of ways to regulate them and cover them up, so you never have to deal with that. So that's an option for a lot of people. The hot flash is always called a pretty good measuring stick because most people will have some and they're there, they're not kind of thing. A lot of other things are a little more vague. Sleep disturbances creep up, and we're going to talk about each of these separately in a minute. The genital urinary syndrome of menopause is the long word for the old vaginal dryness and discomfort with intercourse. We're all more tuned in to our brain health. That's also something you hear a story about almost every day. So we'll talk a minute about that. And then things we don't like that involve weight and hair and skin changes. So those are kind of the big topics we'll hit on. We don't want to forget that this group still needs contraception. The women in their 40s are about as bad as the adolescents at thinking they have to worry about it. They're kind of past the years of concentrating on reproducing and they figure they're done. But a lot of pregnancies do happen. Unintended doesn't mean unwanted, just means they weren't planning on that. And in our world, we often say if you're not taking contraception, you're planning on being pregnant, just the way we think about it. It's nice to know that in some cases that the chance goes down over time because even a regularly cycling woman around age 50 only has about a 1% chance each month. So oopses aren't going to happen as often as time goes on, but nothing's impossible. The definition you always hear is a year without a spontaneous menstrual cycle is what we consider postmenopausal. So you're only menopausal one day, and then after that, you're postmenopausal. So when you have that one day, it's been a year, have a party, go out for cocktails, whatever you want to celebrate. It doesn't promise that nothing else will happen because I always say that uterus doesn't know about that definition we made up. So most women are done by the age of 55, like 90%. So well into not having to deal with cycles and bleeding anymore. Average age is about 52 in this country. You can check labs to help you figure it out if you're not sure. Sometimes with hysterectomies, ablations, progesterone IUDs, we've made cycles go away. So do we have to know when that last period is? Not necessarily. If you're unsure, you can do some labs to just see if someone's in a definite range of good or hormones are gone. But there's a lot of gray zone in between. So when folks will sometimes say, I just need my hormone levels checked. Like if you're still cycling, they're normal. If you're not, they're low. We save some money. But that doesn't always work. That's just the big picture. But quite often the levels can change on a daily basis. And when cycling and ovulation's irregular, we're going to get an answer that may not really be defining what the big picture is. So it's optional, but not a way to figure out exactly what's going to happen next. The nice thing about birth control is there are lots of restrictions for it, but it's for medical considerations, basically. It's not for age. So as long as there aren't any other routine medical contraindications, all the methods are available throughout our lifespan of reproduction. And we keep trying to invent more of them, but we have some good old standbys, the pills, patch, ring. IUDs are very popular, implants. A lot of times women have a vasectomy in their spouse and they'll put down that they don't use any birth control. I say, well, if that's who you're having sex with, that's your birth control. So keep that in mind. Sterilizations are still out there. Most women get to spend a few years with irregular cycles. Sometimes they may get closer before they get farther apart. Not always appreciated. I've had maybe 2 people who said they were regular and then nothing else happened. It's like, don't tell your friends because that's not how it usually goes. There's usually some built-in surprises somewhere along the way. And people can be symptomatic with night sweats and things, even when cycles are still regular and haven't started doing anything different. So you don't have to wait till they're done and then, oh, now I can take something. We'll bridge that gap. It's just because we're not ovulating on a regular basis or after menopause, we're not ovulating at all. So we don't want to just assume that's what it is every time. You know, if the age is right and the symptoms are right, we're going to look into it if things do not make sense. There are different reasons someone may have outside risk factors, medications, hormone therapy. We know obesity. We make estrogen in our fatty tissues. It's a weak kind, but it can still affect the endometrium and affect bleeding. And then it's a different scenario that we have to consider for the wellness of that uterus. So we do look into it. Most of the time, there's nothing anatomic like fibroids and polyps that are very common. It's just a uterus getting the wrong messages sometimes from the ovaries. It's not that smart. It just responds. It doesn't know how to do a whole lot on its own. Mentioned hot flashes. That's something most people get to experience. They may just last a few minutes. They may be only nighttime, which is when they like to sneak up first. They can obviously be in the daytime, be interfering with work and social engagements and things. Most of the ones at night are going to wake you up, like 70%. So then we have the whole conversation about the importance of sleep. So they are associated in that effect. Most women have some, but not everybody decides to do anything about it. There are lots of over-the-counter supplements. Some are soy-based, which is a plant type of estrogen. Others have various other herbal ingredients. And a lot of people will find that gives them relief they need. The main difference I will use in counseling is like that may take care of that symptom. The FDA approves estrogen to treat hot flashes and to help prevent bone loss. So I always like them to know there are some medical benefits to keeping it going, not just that hot flash symptom. It does vary by ethnicity. So there are some who have them worse than others. Obesity, as I mentioned, makes a little bit of a weak estrogen, but its insulating factor wins. So when you need to cool off and your brain in that little narrow thermoneutral zone it wants to keep you in says, oh, you need to cool off, let's vasodilate. They can't cool off as well because it's just insulating. Tobacco use, bad for bones and gives more hot flashes. So those can always be changed if lifestyle is contributing to the problem. We used to say nobody died from a hot flash, but we do know now they're associated with cardiovascular disease. So those who have had gestational diabetes or preeclampsia may have more hot flashes, and those illnesses are associated with cardiovascular risks as well. Our LDLs, cholesterol, the low density, go up a little bit. Our HDL, the good one, doesn't work as well. Blood pressure can go up. There can be increased new onset diabetes after menopause without estrogen. So we have some medical related issues that correlate with the worsening of hot flashes. So if someone has them longer for more years, that can be a potential negative. If someone has them for a while, they're gone, they're in their 70s and now they have hot flashes again, it's not an estrogen related hot flash because it's not from estrogen being taken away. Now you have to think of other medical things and medications and such. So we're seeing that a little more now as women who missed the boat on getting a hormone therapy early are now coming back. Hey, they say it's good. Can I have some now? The study years ago that said, oh, it makes more heart attacks and dementia, the average starting age was in their mid to early 60s. So that's a negative if we wait too long. So that's why I just tell people you may not have bad symptoms. Here's some other reasons to keep it going. And eventually, if you ask for it, we might say now it's a bad idea. So just like to get that little word out there. The other big topic we see a lot, which is one of the things we can also fix pretty well, so I like that, is just the big VSM, which is the fancy way of saying urinary and vaginal discomfort, dryness, thinning of the tissues that leads to some symptoms. So most people will have some symptoms, and vaginas don't get better over time. So they're only going to, once they get thin, they're going to keep getting thin. So we like to try to fix them early on if there are symptoms. So the dryness may be just with even wiping with clothes, with normal activity or exercise, that things are uncomfortable. You can get more urinary tract infections because the epithelium of the urethra misses estrogen and thins out. So UTIs can become more common. Everybody's not having sexual activity, but certainly the pain with intercourse, fancy word being dyspareunia, can be another way they know that things are bothersome. So when the estrogen goes away, there's less of the right bacteria in the vagina, which makes the pH go up, which makes other things like BV and such sometimes enjoy being there more. So we have some other vaginitis issues. And the tissue thins out. It's a 3-cell layer sort of epithelium, and the top layer just gets really thin and doesn't like being asked to be stretched or have some friction. Things like that can be uncomfortable. Luckily, vaginal estrogen is basically for everybody except someone who's actively getting breast cancer treatment. Even after treatment, they don't have an increased risk in recurrence of breast cancer because vaginal estrogens are totally local therapy. They're not systemic or absorbed or increase your blood levels. So basically, everybody can have them. Blood clot history doesn't matter for vaginal estrogens. We have a number of products. 4 of them are estradiol, and 1 is the DHEA that converts to that vaginally. 3 out of 5 have generic, so yay. We can give it to most everybody for a decent cost. And if that's the only thing bothering somebody and they don't want systemic or can't take systemic estrogen, they can have their vaginal estrogen. Lubricants per event, as I say, moisturizers also over the counter to keep tissues comfortable. Sexual activity improves blood flow. Every time there's sex, there's better blood flow. That tissue stay a little healthier. And I put laser on there only because it kind of peaked and it's sort of fallen out of favor a bit. Some of the vaginal treatments that do intentional damage to the epithelium so that it has to heal, theoretically healing with better collagen, better support, and new tissue that's more lubricating. But there was a lot of post-treatment pain scenarios, so it kind of fell out of favor a little bit. But it's still out there, called the Mona Lisa by one of the brand names. One of our menopause meeting, there was probably 10 vendors. A few years later, there was like 1. They'd already kind of seen their peak. We do hear a lot about decreasing libido. Sexual activity can be decreased if there's discomfort or pain. So we're always going to say, let's fix that vagina. So at least it's not a negative event and that you want to do it again. HSDD is hypoactive sexual desire disorder. which is technically a psychiatric diagnosis, but it has some criteria that are basically that you don't think about intercourse, you don't have fantasies, you don't care about it, and it's creating a relationship problem. Most anybody who's bothered to mention it, it's already bothering the relationship in some way. So I don't label people with that. I just code low libido, and that's an easier way to go about it. It's not directly linked to hormone levels. So we hear a lot about testosterone nowadays. Testosterone decrease is totally age related. It doesn't go down at menopause. It goes down between our 20s and our 40s by about half, and then it just stays there. So 10 years later, when you're menopausal, it's not going down anymore. So we're kind of having to bust that myth that this is the time to start it. The time to start it is really a little earlier. Um, we can replace it with topical. Oral is the unsafe way to take testosterone. Topical skips most of the lipid concerns. It comes in compounded most commonly. There are some men's products we know how to titrate for women, but it can get a little tricky to try to get the right dose out of them because we need a tenth of what they use. So if someone has a spouse using that little tube or packet, you're supposed to use a tenth of that little packet or tube, which means it lasts longer, but it's pretty hard to measure. So we often use the compounded. When people use other methods, they're still considered transdermal shots, pellets. They're anything but oral, again, is the safer way. They often are getting levels into the hundreds. So your normal level most all your life was probably between about 15 and 50, never a triple digit. So when you get the excessive levels of 200 or 300, you may for 3 or 6 months get some of that boost of energy and libido. Long term, it doesn't seem to stay. Those excess levels, if I tell women the 4 things on the bottom of that slide, they won't want it. Increased weight, blood pressure, unwanted hair, and then hair loss on the head. So nothing that anyone's come said, please let me have that. So excess levels have negatives, cardiovascular negatives being the main medical risk. So as much as I'd love for everyone to feel more playful, it does come with some risks if you try that. So we do give it back, but just in a safer way and to keep us in the normal female reproductive range of testosterone. Mood disorders happen a bit more around this time as well. Estrogen's not a treatment for mood disorders, but it does have a little benefit to our serotonin. So a whole bunch of the antidepressants now are helping the brain keep that serotonin or feel good chemical in our brain. So it does have a little bit of a benefit in that respect. Those who've had mild depression, either episodic issues, sometimes postpartum depression, things that were temporary, they can have an increase at this time because usually a lot of the hormone fluctuations are what really disagree with us when things are not predictable anymore. New onset depression can happen. Major depression, lifelong, long treated, really doesn't usually change very much. It's mostly the fluctuations. If you ever saw that little graph where here's our cycles, our estrogen, our progesterone, and what our endometrium's doing back in school when you learned about it. If you look at one in the perimenopause time, it's just all over the place with peaks and troughs. So the ovaries don't do their job. They get told again. They may make this weird peak in estrogen, breast tenderness, other things, bleeding irregularities. But those fluctuations are really what cause more people the problems with their moods and issues at this time. Luckily, they're also the ones that estrogen helps to fix the best. When they even out those fluctuations, they get even a little bit more of a better response than those who are just using it for their usual reasons like hot flashes. We know that depression and mood are linked to the hot flashes. They will report more hot flashes. And the sleep is poor. And none of that goes together to make for a good next day or a good mood. So we do find it helpful as part of what we do now. So a lot of women do need to use an antidepressant or something just for even a few years, not long term. Again, sleep is always talked about at our menopause meetings because we know it's important. It helps, again, your days be better, your health be better. Then there is a relationship of sleep to vasomotor symptoms. That's not a big surprise. The FSH, which is a follicle stimulating hormone, our brain telling our ovaries to work, it goes up when we get menopausal because it's yelling at the ovaries. That's the way I think about it. They're not answering, so it sends more and more message. But that doesn't directly relate to the sleep issues. But 50% of folks are going to have some issues during perimenopause. Long-term, insomnia does get a little bit worse. And the main thing I tend to hear about is middle of the night wakening. People are tired, they go to bed and they go to sleep, but 3 a.m. it seems is a bewitching hour for a lot of women. I just hear that time more than anything else. And there are normal changes in our rhythms and our sleep cycles. A lot of people wearing the rings or watches nowadays so they can track all that. They may see when they have their best REM sleep. And there are folks who are sleep medicine docs who can help work through some of this too. The bioidentical progesterone, especially that we use, a lot of people say, oh, I take it because it makes me sleepy. It works on the same receptors as a lot of anxiety meds, the GABA receptor. So it does calm us down. So people do find a sleep benefit with it. There are people who take progesterone without yet taking estrogen. That's okay. You just can't do it the other way around. And estrogen can have a similar little bit of effect on that for sleep. The little darling discussion of the menopause meeting this past year was doing cognitive behavioral therapy for insomnia, which was recommended before other kinds of sleep medicines. Mostly it's a 5 or 6 session where they teach you not, it won't make you not wake up, but it's helping you learn how to go back to sleep so that you don't lay there awake for hours afterwards. But when people can do that and get back to sleep, then those awakenings are not as big of a problem. Needless to say, I hear about the weight gain on a routine basis, which no one wants any of that as a general rule. Most people get about 5 pounds right around the time of menopause, usually right in the middle. We have more cortisol receptors there, and they have more available cortisol. And there we go. But the postmenopausal weight gain is a continuing thing. The other thing I will say, kind of like the testosterone is not directly menopause associated, weight gain is age based. It happens whether you do or don't take hormone therapy. So it is something that just unfortunately happens. And there's nothing good to say about it on this slide. Sorry. But our fat gain rate increases, our lean muscle mass, we decrease. They like the phrase body composition a lot this past year, meaning muscle fat ratio shifts whether you take hormones or not. So it can start before that last period is happening. And when women age, we have more obesity issues than the men get after this time frame. But hormone therapy is not the culprit, nor is it the helper. I say unless it helps you sleep and then you actually feel like being active the next day or going to the gym. So it may have a secondary way that it could help, increasing and benefiting mood and such, but otherwise it directly doesn't do that. We're having a decreased metabolic rate at this time. So basically you have to do more, eat less to even stay the same. Again, not really fair. We get increased visceral fat, which is the kind you hear about. That's the more concerning inflammatory type of fat around our organs. We don't metabolize our glucose as well. So I tell everybody, get moving after supper, especially this time of year. Don't sit down. It helps us get our insulin, get things metabolized better. Protein's also having a moment, I believe. I mean, even Starbucks has it in their drinks and everything else these days. There are some people who think this is just crazy talk, but mostly we probably weren't eating enough to begin with. We do need to have some at the start of the day, which an American diet kind of starts out carby and ends up with the protein. We need to have some in the morning. It ends up being 25 or 30 grams a day, and that's the calculation at the bottom, like for how much you would get per kilogram per day. But you should have it throughout the day, not just at the end. And there's lots of sources of it. Morning is a little trickier just because we're not meat eaters so much in the morning, but yogurts and other things, or put it in your coffee, get a powder, whatever we can do. Skin and hair changes are ongoing at various times in life. Truthfully, there's a lot of people who notice that postpartum loss because those follicles were all resting together and the hormone drop, progesterone drop, now they're all shedding together. So we know there's times that we have telogen effluvium, which is a fancy way of saying a thinning out. But normally that's followed by a regrowth for whatever reason triggered it to happen. So it can be a lot of times related to stress. We all think we probably just have baseline stress. We probably do. But it can be stressful incidents, episodes, emotional ones, physical ones, surgeries, things like that. A lot of medications aren't kind to our hair. Beta blockers aren't good for hair growth, a very common blood pressure med. So we always want to look down that list and just see if we're doing anything we could undo that might not help. We look for hormonal issues. We check lots of thyroid for that. Ferritin, your iron stores can be related to this. Again, other medications, other hormones, lots of other things. So we want to make sure it's not a testosterone type of hair loss, which is more the receding frontal and then the balding in the back. Very few times have I seen a true skin condition like alopecia where you have areas of hair loss. So we will send people to dermatologists if it seems like it's more of an issue in that respect. But excess testosterone miniaturizes the hair follicles, shorter growth phase, so it doesn't help. So excess of that, again, another reason we wouldn't appreciate it. A lot of the medications you see, minoxidil, spironolactone, to block the function at the hair follicle level are used. I don't have TikTok. I have seen all the things like on Instagram. There's every fifth thing is a hair supplement. Don't do this. Throw all those things away. I'm not sure I know what the right answer is, but nutrition is a part of it, as well as looking for inciting factors. So I always joke and say if there was a way to have better hair, I'd have it too. But this is all I got in the first place. Cognition. We're all worried about our brains. We got to try and stay on top of things. So it is a time where we become aware. The main type of just a problem that women have at this age is just verbal recall, meaning I say you can define the word and be like a thesaurus and tell other reasons, but you can't say the word, just won't come to you. That's not related to dementia. So that's a good thing. Estrogen isn't recommended for a treatment, and in the Women's Health Initiative, it increased dementia because there was probably already some atherosclerotic type disease. So that's the scary thing about starting it too late. Starting it early is neutral. They're studying it. Maybe someday they'll tell us it is a helper, but we can't really say that right now officially. Excuse me. For again, sleeping and hormone therapy to treat vasomotor symptoms can be beneficial. Those who had a menopause, they cruised through, no symptoms. It doesn't seem to make as much difference. Those who had surgical, where we took their ovaries out and it was going to drop all of a sudden, seem to also benefit a little bit more. We don't give it or not give it for those reasons. We give it everyone's an individual conversation if they want hormone therapy. Unfortunately, the testosterone wasn't really shown to help anything, particularly with cognition or what we call brain fog. That also wasn't shown to help our muscles or our bones or anything else. I was hoping they were going to tell me. So it doesn't have a lot of medical benefits, but we do give back the testosterone for potential mood libido benefits. Many people have had MRIs for various reasons, for those who've had various headaches or injuries or things. So there are hyperdensities that can be associated with hot flashes, and those can be associated with cognitive disease, but they also can show up in people who've had migraines. So it's not a direct correlation. Almost makes you scared to look if you have migraines and then wonder what your brain's up to. But brain atrophy itself is just an age beige. So that's just the shrinking of our brain tissue. Many people know about the genetic risk where the APOE4 can be something they carry. I think I heard a story. One of the main researchers, he has that, but he says that it's not a guarantee. There's so much lifestyle things you can do that can help otherwise. So inflammation is the other thing you hear about to help our brain health and not worry as much about our future cognition. Osteoporosis, got to throw that in. There's one of our main things. I send everybody down the hall if they're old enough and qualified to get a bone density, because by the age of about 40, we've already got what we're going to get. We don't keep building. So the screening age is 65, which seems way after the fact. I would like most people to know beforehand so they can start preventing the loss a little bit better. But it does increase with age. It's more in women than in men. We got some genetics that go into that. Again, lifestyle, smoking bad for your bones, drinking, poor nutrition in general. Low BMIs can be a problem too. Around the time of menopause, we lose about 2% a year, whereas our normal baseline loss is 1% a year. So again, we're not gaining. Estrogen doesn't make you build bone, but it helps slow down the loss. So I always say it's a delay tactic for that 2%. You're just going to hold that off for a while if you keep estrogen in your system. Medications used for breast cancer, chronic steroid use, medications used for stomach acid, those can all decrease our bone mass. The GI ones, especially by having us not absorb our calcium as well. So there are times people have more risks. And I was real excited when I found the code for osteoporosis in mother that I can use for a lot of patients to get them an early bone density if their mom had that or a hip fracture. We're honest about it, but if we can find a good reason to get one before 65, usually we will. And it's very easy compared to everything else we tell you to do. You just lay there. No prep, no nothing. So it's not as hard to talk people into. Just thinking of the diseases we know can come up. We mentioned osteoporosis. Breast cancer risk is still about 1 out of 8. So mammograms depends on whose guidelines you look at. Start around age 40 for baseline if there's no other family history. Between 40 and 50, every 1 to 2 years. After 50, most of the organizations agree to yearly. At the last menopause meeting, they said they still find 5 or 6% of breast cancers between 75 and 80. So 75 used to be a stopping age. Now they encourage people to keep getting them. Pretty easy screening and doesn't last long. People just dread it for it's uncomfortable. It's like time them. That's like 2 minutes out of your day. And we can do this. Cardiovascular disease, main killer of women and most people. So we know that estrogen helps protect the lining of our blood vessels, so we get less atherosclerotic heart disease. So yay. We will try to keep up with screenings. You have calcium score now that people can do for extra information. Colon cancer in the news as well, with a little bit younger population. Estrogen seems to decrease the risk a little bit, but still the screening colonoscopies now at age 45. And a lot of people are doing the home tests, the Cologuard screening. And then I've seen ads for some blood testing for tumor markers. I suppose I don't know as much about those, but colonoscopy is the gold standard because they see anything, they're going to snag it out of there at the time. So a lot of people would do, we could spend a whole hour just talking about hormone therapy in general. But the old phrase used to be lowest dose for the least amount of time. But with American College of OBGYN, we don't have any guidelines for taking it away, aside from a diagnosis that means it's now not recommended for you to have it. And the main one I've ever seen for that is people developing breast cancer. Estrogen doesn't make a cancer cell. A cancer cell mutates to become a cancer cell, but as you know, a lot of them have receptors for estrogen or progesterone, so it may help them grow. So that's the main reason I've ever had to stop people's hormone therapy. But we have lots of regimens. But the only people who can't have it are those who've had breast cancer, uterine cancer, blood clots, strokes, and even those have some little side discussions for how did it happen or what happened. The guidelines that came from Women's Health Initiative was if you haven't started by age 60 or 10 years from your last period, now you have more risks and benefits. We still kind of use that as a guide. As far as what is available out there, we have a lot. There are a lot of generics. There's pills, there's patches, there's topical gels, creams, vaginal ring. I jokingly say, where do you want to put it? Shots and pellets give the same chemical, estradiol. It's just getting a little bit of a bolus and then it goes away. So if you like roller coasters, is what I say, that's fine. But if you like to feel the same every day, then usually we're going to pick one of the other methods. So most of them have generics now, the gels, the patch, the pill. So and it's bioidentical, it's estradiol, the main one your body makes. Estriol and estrone are both weak estrogens, so including those really doesn't make that much difference if you're trying to fix symptoms. Testosterone, we kind of talked about. There aren't any products for women. Australia has a patch, but we don't. But we use the other, either men's products or the compounded most traditionally. Golden rule, as I call it, if you have a uterus, you have to have progesterone because estrogen wants to build up the lining, progesterone wants to hold it in check. So you need to have those basically cancel each other out. So to get no bleeding, which we can stir up in the first few months after hormone therapy, doesn't mean we have to investigate it. We started the problem. It's just getting itself to a new normal, a new steady state. So when people take their progesterone, we have different regimens. We use a lot of the bioidentical progesterone as well. Topically, it's not very good. So compounding, making topical cream doesn't get absorbed. The compounding pharmacist will tell you that it's a big molecule. So we really can't trust topical progesterone to protect your uterus. We really have to go another way with the products that we have, both synthetic and bioidentical. So like I said, hormone therapy in general, a whole nother topic. It's a matching of what someone wants, what they can fit into their regimen, what's safe. Transdermal skip our mouth, our liver, and pretty much all the blood clot risk. So we certainly encourage the patches and topical gels over a pill. Pill's the cheapest thing. So we do use that when we need to. Because basically, if you can have one, you can have any of them. It's not like you're only going to give you one version for the most part. There's combination pills and patches. So you can have both ingredients in one dose. They're separate, again, estrogen forms, and then we pair it with the progesterone orally. So we can do it in so many ways. It's quite the buffet of options. And most people we're just gonna narrow down that discussion until they have gotten to something that will work in their routine and their regimen, and that they'll take and remember to take. Again, we stir up annoying spotting, but that's not something we usually can't adjust for. So we work through that. And I think that's all, with a little bit of time for questions. Told you it was speed dating for perimenopause.
That was great. That was great information. I know it's a lot of stuff to try to fit into a somewhat short amount of time. Like you said, you could probably on each of those just expand for, each one of them have an hour presentation to themselves. We do have some questions in the chat that I'm going to help go through with you. So the first one, how do you know if you have the right balance of estradiol patch and progesterone? Are there signs your patch is too strong?
The patches and the topical gels have about 5 or 6 strengths. So I always say the main thing I want to do is fix your symptoms. The main thing I care where those two hormones are acting is fixing your symptoms. And what does the uterus think about it? Because we want you to feel better. And we want to know that we haven't stirred up any thickening or thinning, because either way you can get irregular spotting. So it's really all about those two things, just to make it convenient as we fix the symptoms. Let's see what that is. Sometimes we're adjusting, sometimes we have to figure that out. It doesn't, we don't always get it right first try. The combination pills and patches have theoretically done a little bit of that for us, hopefully studying them, making sure that they know um, that we were a study site for one of the patches decades ago. We didn't know what it was going to be, but we were doing biopsies and ultrasounds with people in the patch dose to make sure that the lining of the uterus was normal and staying that way. It doesn't mean someone won't get spotting or anything, but we do try to adjust for that. So fixing your symptoms, and we've stirred up any annoying problems.
Great. And does perimenopause begin earlier if you've had a hysterectomy but left ovaries?
A debatable topic quite often. Most people think there's a little increase in time. There was like a little blood sharing, but the ovaries have their own artery that is still left to itself. It comes from the side walls of our pelvis, not from the uterus. So they would always put their hormones into our circulation. That took it then back to the uterus to respond to it. But it seems like there might be a little, we're talking like within a year or so, not a big difference. But I always tell people, just because I can't prove it or do a test for something, how they feel is how they feel. And, we work with that. So we don't go, that doesn't happen. You don't know.
Wonderful. And then another one, could you go over the concerns about taking testosterone orally as opposed to the cream?
Progesterone? Did you say progesterone?
Testosterone.
Oh, testosterone. Orally is where we get lipid changes, so it's bad for your cardiovascular system. I mean, ask a cardiologist if they want women taking oral testosterone. There is still a product out there. It used to be called Estrotest. It's still out there as a generic that is an oral pill that is estrogen and testosterone combined. Very rarely used anymore. It used to be more so for those who actually the ovaries came out, so they actually were missing some of their testosterone before that normal lowering of time. But it's mostly the cardiovascular risk increase that is just a negative taking it orally. We weren't meant to have men's levels, and even if we have high levels, our tissues don't see them the same as a guy.
Really good to know. So another one asking, I work out a lot, which is fantastic. Working out, exercise a lot, and I find that my patch slides down or comes off completely. Is there a better way to keep it on, or is there a better option possibly?
I always say patches, put them on clean, dry skin, lower belly or upper backside is not the part you sit on. We try twice a week ones usually if they're not staying on as well, just because it only has to stay on 3 to 4 days. And then if that is really still a problem, we'll sometimes go to the topical gel packs, where it's a little packet you just put on the skin every day. The vaginal ring that's out there, fem ring, lasts for 3 months at a time. So if that's comfortable and you like it, and maybe use the contraceptive ring, it's a low maintenance way to get it back in your system. The patchy, some people get skin irritation too, so we'll take it away for part of the time. Trying something else, not take it away. We try not to take it away.
Good to hear that there's some other options out there that could be tried.
Oh, yes.
Fantastic. So how can I get a bone density scan before age 65?
Well, that's what I do, creative as I can. I always ask, did either parent have hip fracture or osteoporosis? Did they ever use chronic steroids? Some people who are on blood thinning medicines. I mean, I'll say anything that is the truth that I hope can do it. Most people, it seems to fly if I just label them as postmenopausal without even saying there's a problem otherwise. They'll usually be told what the cost will be beforehand. So that they will know at any out of pocket. There are other screening places, the separate independent places like Touchstone and some others that can do things for lesser cost than other facilities. So I was asking the insurance, do they cover it just because you're postmenopausal? I mean, I want to say I've already peaked. I'm not going to get any better. It just seems like we're wasting 15 potential years of when we could have made things better. So that's why I tell everybody, eat your calcium, take your D, Most everybody can take 4,000 of D over the counter without being monitored at all for taking any excess. There are high prescription doses, but I check Ds all the time. It's related to mood and fatigue as well as our bone health. So I'm always checking that because half the population's low. So just doing all the things we can normally to try and keep our bone density better for whatever we've built up to that time.
Following along with that, I think you kind of touched on it, but can you qualify for the bone density test if you have osteoarthritis, and do you recommend that?
Yeah, arthritis really isn't the same. So it doesn't. So it doesn't really get us in there, osteoarthritis or rheumatoid arthritis. I do see a lot of rheumatologists who will do bone densities, but that makes sense. They probably even have more creative ways of getting it covered. Um, but it's mostly related to things that led us to our bone building years or things that created increased loss.
All right, and should estrogen and progesterone be compounded, patch, or is a tablet caplet okay?
Um, the compounding pharmacists make topical estrogen, which is fine. Again, the progesterone doesn't get absorbed through our skin adequately. So if I'm giving estrogen, I can't reliably give progesterone topically and trust that I'm protecting a uterus. Orally, now the progesterone, bioidentical progesterone pills that we use off label, they can be placed vaginally or rectally if people like that. The main thing that will do is take away that sedating effect, though, which is why a lot of people like to take it. Um, but can't trust the progesterone topically. But compounders can make almost anything you ask for. Uh, you always will get to pay for it. Insurance never pays for compounded, rarely, unless it's something that it doesn't exist. Otherwise, it's a special something that someone needs.
All right. Great questions coming through, so we'll keep getting through them. So, can taking estrogen cream help with vaginal inflammation if you have a high pH balance and low lactobacillus, and it's been confirmed you don't have DIV or any vaginitis issues?
Yeah,
Sorry, I butchered that.
yeah.
Vaginitis issues. Sorry.
We had some nice speakers a couple years ago, and I swear they just come from the labs in their flannel shirts. They were like the research gals. But they were talking about, you can shotgun all the different vaginitis things, do boric acid to lower the pH and antibiotics for the various infections. But they said, if you just put the estrogen there, the microbiome, as the nice word is, will basically correct itself. So, they encourage the vaginal estrogens to just help keep the normal bacteria there. The lactobacilli are what keep our pH normal. The vaginal estrogens too actually have a little side benefit of helping with some of the urgency incontinence, the kind where as soon as you unlock the door to the house, you go. It helps with a little bit of that. But yeah, putting a topical vaginal and the little tablets and things, it's even once or twice a week. It's not like onerous once you're kind of got started.
All right. And is there a correlation between arthritis or joint pain and decreasing estrogen?
I'd say the joint musculoskeletal discomfort has made it into like the top 10 list of things people notice in the perimenopause that seems to be benefited, mostly because estrogen is good for connective tissue and collagen. Is probably how it helps. They made a point of talking about frozen shoulders, like don't go have surgery, do PT and get some estrogen, and as long as that's something the person wants to do, then that's okay. So there is some relationship with the musculoskeletal discomforts.
Interesting. I think we got a lot of great information, and I appreciate everyone's time. Like I said, I'll send a follow-up email with the recording. And again, some of these additional questions that we didn't get to, I'll share them with Dr. Miles, and in the follow-up have those answers for you guys. Thank you guys so much. Have a wonderful day.